G'day. Today's web lecture is to talk about how ICUs are operated, particularly the surgical ICU, and who's in charge in the ICU. The objectives of this lecture are to learn the effect of an intensivist on outcomes, improved outcomes in closed ICUs, economic effects of intensivist-led care, the limitations on intensivist adoption, and the effects of a surgical intensivist on the ICU. The history of the ICU basically is a history of modern medicine and surgery, starting with the improvements in nursing care during the Crimean War, as brought on by Florence Nightingale, and then during the polio epidemic in Copenhagen in the early 50s by surgeons such as Dr. Walter Dandy, doctors like Dr. Peter Safar and William Mosenthal, who noted that post-operative care of patients in the surgical intensive care unit was a separate field that required very intense work and dedication and education for a specific group of physicians and nurses. The intensivist itself is a new subspecialty. The first fellowship in the United States was in 1962 at the University of Pittsburgh. Specialists from the specialties of anesthesia, internal medicine, pediatrics, surgery, and emergency medicine can become intensivists. Along with the concept of the intensivist is the closed versus open ICU. A closed ICU is operated by an intensivist. In an open ICU, the attending and residents from primary services write the orders and direct the care of their patients. An intensivist may be present as a consultant. In a closed ICU, only the intensivist and his team write the orders with input from the primary services. In the United States, about 60% or more of ICUs are open. However, in many other English-speaking countries and in Europe, 80% of ICUs are closed. What difference does it make? This is an intense emotional issue for the specialties and physicians involved. It does have impacts on the quality of care, on the staffing of the ICU. There are issues in terms of the scope of practice and OR access, compensation, control over the care of patients, traditions in various specialties, and hospital politics all have a role in determining whether an ICU will be open or closed. Some other questions, though, we can look at is whether or not there should be a critical care team. When there are daily rounds in the ICU by an intensivist, it is noted that there is an increased use of monitoring and a lower mortality for patients in the ICU. In a paper appearing by Frobenius et al. 1999 by JAMA, there was a 3-time reduction in in-hospital mortality with the institution of a critical care team. Any ICU, open or closed, should have a critical care service. Should there be a full-time ICU director? A study from Canada showed that in the first year of an ICU's operation, where the attendings were directing the ICU, compared to a second year when it was directed by an intensivist, with patients having the same severity of illness, there was a 52% reduction in ICU mortality and a 36% reduction in hospital mortality. Should the ICU be closed or not? This is a very controversial question. There is evidence that there is reduced mortality, reduced ICU length of stay and reduced ventilator days, reduced cost, length of stay, and complications from several papers. Nurses working within the surgical intensive care unit are more likely to indicate they are more confident in the clinical judgment of a physician primarily responsible for patient care in a closed ICU as opposed to an open ICU. The effect of the intensive care unit and how it's organized in terms of specific diseases has also been studied. In a study of 10 open and 12 closed ICUs in 16 hospitals near Seattle, Washington in 2000, it was noted that even with the effect of more consultation, trauma patients, increased transfers, and hospital volumes all removed, the mortality was still 32% lower in closed ICUs for patients suffering from acute lung injury. The effect of intensivist-led care on trauma-related mortality has also been studied. A paper by Avery Nathans while he was at Harborview showed that the relative risk of death in an intensivist model ICU was 0.78 compared to an open ICU model. And when it was led by a surgical intensivist, that is a surgeon who also has a subspecialty in intensive care, that the mortality was 0.67 of the open ICU model. In designated trauma centers, this decreases still further to 0.64. This is a strong support for the idea of a surgical intensivist-led ICU within the trauma center. The Leapfrog Group is a U.S. business consortium of more than 150 public and private healthcare sector purchases. They recommended in 2000 that board-certified critical care specialists be available during daytime hours, that they be able to return to the ICU or arrange for an on-site physician to do so within 5 minutes of being paged. And they estimated that by applying ICU physician safety standards could save more than 54,000 lives in the United States each year. But do intensivists save money? The predicted cost savings ranged in a paper by Provenos et al. In Critical Care Medicine in 2006 from about $500,000 to $3.3 million US dollars for a 6 to 18 bed ICU per year. However, there's been no prospective paper or study showing an actual cost savings with the adoption of an intensivist. The Society of Critical Care Medicine, which is a professional society of intensivists, has submitted a task force on guidelines for the Society of Critical Care Medicine. They suggest that a multidisciplinary ICU team should be led by a full-time critical care trained physician available in a timely fashion to the ICU 24 hours a day, and that ICUs operating in the closed format may have improved outcomes. However, the adoption of a closed ICU in a center where it's been previously open is a contentious issue, and as I said before, involves many issues beyond that of literature. The controversies and some of the resistance extends the fact that studies are mostly done in large academic centers. However, many ICUs are actually in community and rural hospitals. The issue of who's going to hire and pay for extra intensivists also is an issue, and the problem is also that they are in short demand. In the United States, there are about 5,000 ICU. There are about 10,244 intensivists, and only 2,500 of those are actually surgical intensivists. Resistance also comes from the fact that there are few ICUs with full-time intensivists, and when the Leapfrog studies came out, a study in 2001, about 35% of hospitals indicated that they would not or could not follow the Leapfrog standard. However, with the passage of time, about 80% of hospitals now indicate that they want or will get an intensivist. Only about 26% of hospital ICUs, however, meet the full standard. How about the operation of an ICU when there are both intensivists, attendings, and surgeons involved? Surgeons have a specific personality. They tend to be decisive, in control, exude a certain amount of confidence, and seem very certain of their actions. At least that is the image that they portray, particularly to their patients and families. They're interested and can provide the spectacular and definitive cure of the patient. And they're known for trying to provide heroic care in the face of overwhelming odds to give the patient every possible chance. The intensivist, however, sometimes has a different personality. They tend to be more holistic, masters of detail, interested in creating and following protocols, and they tend to be realists. They're interested in incremental and proven improvement for a whole population of patients. They do have an interest in the relief of suffering, and they do recognize that futility does occur and, if not addressed, can be harmful. The key to success is that when major differences occur between an intensivist and the surgeon, that these should be first discussed between the intensivist and surgeon and then with the family. The surgeon may be used to having various consultants involved that may be his favorites, but in the ICU he must allow the intensivist to be the first to manage major medical problems. ICU protocols are evidence-based. However, if the surgeon thinks that his patient is different, he should discuss this with the intensivist. The intensivist controls access and knows all the patients in the ICU. He must be able to override surgeon's wish for one more day to get a sicker patient who may be admitted. What are the keys to success between the interaction between the intensivist and the surgeon? Communication is the key. Surgeons must be notified early of adverse events and have the chance to speak to the patient and family. If you have the chance for your surgical intensive care unit, hire a surgical intensivist for the best outcome and the best understanding between the surgeon and the intensivists. Why are intensivists important for patient safety? In summary, directly by being on site in the ICU to make day-to-day medical decisions, to intervene in life-threatening situations, and to make life and death clinical decisions based on their specialized training and experience with critically ill patients. ICUs with the full-time intensivist on staff tend to have decreased mortality rates, fewer low-severity illness admissions, and less frequent complications. Intensivists also contribute indirectly by improving staff education and proficiency, contributing to the organization and interdisciplinary coordination of the ICU, and the following outcomes have been observed in ICUs with a full-time intensivist on staff: improved physician-nurse communication, development and implementation of protocols and guidelines, and better education of medical students and residents in the management of critically ill patients. Thank you.